Huge welcome to you this evening. Thank you so much for taking time to joining us. My name is Sarah Gardner. I'm chair of the Society of Tissue Viability, and I'll be the moderator for the session this evening. I know that we have an incredible number of people that have registered for this evening's webinar, and I think we all agree that this is such an important topic. The aim of this webinar is to discuss the risk of a catastrophic fire when using powered air mattresses and the actions that can be taken to mitigate that risk. The need to talk about this topic came about when Jeannie, who's one of our speakers tonight, she was chair at the time of the society, and she brought a scenario to the Board of Trustees. And this highlighted the lack of knowledge of fire and bed rail standards when people were procuring equipment. Around the same time, the British Healthcare Trades Association section chair made contact with the society and asked whether they could collaborate with us to raise awareness of the standards. And one of the ways that we're doing that is that webinar that we're having this evening. In addition to the webinar, 3 fantastic blogs have been produced, and they've been written by our speakers that we've got here this evening, and they will be available after this webinar over the next few days, and we'll communicate that through our website and from our social media platforms. If you're going to our conference this year, we'll also be raising awareness of the blogs there as well. So we will continue to highlight these risks through our educational programme, and I really would urge all of you to have these conversations wherever you work across the UK. So tonight we have 3 fantastic presentations by our speakers. We have Jeannie Donnelly, who's a lead nurse in tissue viability and an honorary senior lecturer at Belfast Health and Social Care Trust and School of Nursing at Queen's University Belfast. And she's also been a past chair of the Society of Tissue Viability. We have Peter Cassidy, who's station commander in Northern Ireland Fire and Rescue Service and Ulster University. And we have Dr. Berend de Haar, Director of BES Healthcare Limited in Bristol. After the 3 presentations, we'll have plenty of time for a panel discussion, and this will be shaped by the questions that you hopefully will be putting into our chat or to our Q&A function. I'd like to introduce again Dr. Jeannie Donnelly, and Jeannie qualified as a registered nurse in Belfast in 1988 and spent the first 8 years of her career working in a fracture trauma unit at the Royal Victoria Hospital. And this is where her real passion for tissue viability and wound care started. And Jeannie was the first tissue viability nurse on the island of Ireland. Yeah, that is something to be proud of, Jeannie. So, Jeannie, I'm going to hand over to you for our first presentation. Thank you very much.
Thank you, Sarah. And folks, thank you very much for joining our seminar this evening. I think that the numbers registered show that this is a very important topic to practice, and it's one that requires a multi-agency approach. I am acutely aware that I do not have a definitive answer to what is a very complex problem, but I hope that this seminar will spark, pardon the pun, a national conversation which enables us to learn from each other and share best practice. So this evening, I want to articulate the adverse outcomes associated with the development of a Category 4 pressure ulcer. I want to recognise some of the human factors which must be considered before we provide a powered mattress to people who smoke. I want to think about potential intervention strategies and their effectiveness in minimising those risks associated with accidental fires, and also, as a team, to examine the role of individuals and agencies that are in contact with people at risk and how they can be employed to reduce the risk from fire. Now, If you're a Star Trek enthusiast, or like me, are fortunate, I think that's the word, to be married to a Star Trek enthusiast, you will have heard of the Kobayashi Maru scenario, and I've shared this many times, and you can recount it in detail. This sadly is my house and my husband's so-called priceless collectibles. And you might notice that his prize photograph is not me nor the kids, it's William Shatner. So why am I referring to that scenario? Well, for those who are not familiar with the scenario, it's a no-win training exercise where a cadet is responsible for rescuing a ship called the Kobayashi Maru from attacking Klingons. And if the cadet chooses not to save the ship in distress, it will be destroyed with all hands. However, if they go to the ship's aid, there will be an all-out war, and the cadet and the crew will die in the attempt. Now, back on planet Earth, I think we as clinicians are often faced with what seems like a no-win situation. The question then becomes, what is the best and safest course of action to take? Should we retreat? Should we wait? Or should we advance? And I think it's important to note that best may not be the safest, and safest may not be the best. Mark Maneely, who is a lecturer and a writer in business, states that to successfully retreat, you must accept that a situation is irredeemable. And I think that whilst that might be black and white in terms of a business relationship, clinicians cannot retreat from vulnerable patients with wounds such as pressure damage. We have a duty of care, and we must work within our team to ensure that the person is cared for as safely as possible. In clinical terms, waiting possibly equates to maintenance therapy, and this can be a viable approach for a short period of time and in a defined set of circumstances. However, if you passively wait, you're at the mercy of events, or rather, our patient or client is at the mercy of events such as infection. They will most certainly have a decreased quality of life. And Mark Maneely suggests that one should always perform due diligence to test the chances of things working out for the better. And notes, it is critical to have a backup plan in case the delaying strategy fails. Most practitioners refuse to accept a no-win situation, and they seek to change the parameters. Now, it is often difficult to do that when you're running around in a circle. You have to stop. You need to assess the scenario. You need to focus on what can be changed. We've got to involve others, particularly if there is a serious risk to life. We need to take expertise on board. We need to weigh up the pros and cons and take a very measured leap of faith. Moving forward takes a tremendous amount of energy and effort, and sometimes the strategy may not work out the way you want or expect, and that for our patients could be devastating. Whatever decision we make, it needs to be an active decision. In other words, we need to actively retreat, actively wait, or actively advance. The decision needs to consider the wishes of the person, the safety of the person, and others in the vicinity, and the knowledge and expertise of the multidisciplinary team. So to illustrate this, I want to discuss a complex situation which involved the care of a young gentleman with a Category 4 pressure ulcer. So this gentleman is 29 years old, and about 6 years previously, he fell from a roof onto a concrete ground and was paralysed. Sadly, he was homeless at the time of injury, and the fall was believed to be an attempted suicide. Now, this patient did not engage well with rehabilitation, and on discharge from hospital, failed to attend for follow-up appointments. In September 2020, he was admitted to hospital on 2 occasions, a couple of weeks apart, due to alcohol excess and self-harm. And the self-harm presented as burns from cigarettes and lighters, as well as multiple self-inflicted lacerations to both lower limbs. His mood was low, and he expressed thoughts that life was not worth living. Now, our patient was supported by a wide range of clinicians and other agencies. In April 2021, he had another admission due to deliberate self-harm and suicidal ideation. And again, he had multiple self-inflicted lacerations to both lower limbs. During 2020, there were further 5 admissions. In January, he was admitted with a fractured tibia and fibula. His foot had dragged under a wheelchair, and he'd waited 3 days before seeking help. Following removal of an external fixator, he was placed in the plaster of Paris, but he failed to return for removal despite repeated requests. In April, he was admitted due to substance misuse and a transient vascular compromise of the left lower limb because of the prolonged use of the plaster of Paris. In June, he was admitted with leg lacerations, and once he was well enough, he was transferred to an acute mental health unit, but he discharged himself contrary to advice because he was deemed to have capacity. In July, he arrived to ED intoxicated, unclear why he was there. He was given antibiotics for cellulitis in his leg, and a few weeks later, he was readmitted with cellulitis again. He was seen by vascular, no intervention, and referred to tissue viability and podiatry. Now, in August, he was admitted with very extensive leg lacerations requiring around 140 staples. Again, due to deliberate self-harm, there was massive loss of blood at the scene. And during this admission, he was noted to have a full-thickness pressure ulcer, and he also had necrotic toes. Now, these pictures are actually representations of the wounds he actually suffered. His second toe was disarticulated, ready to fall off, and he required an amputation. From speaking to his community nursing team, it was clear that in the days prior to admission, he was not granting access to the home, which meant that wounds were not getting dressed. Now, unfortunately, an MRI of the sacrum indicated osteomyelitis of the coccyx bone, which we could see and feel, and he was referred to plastics and infectious diseases. Whilst on the ward, there were issues around challenging behaviour, substance abuse, and on 2 occasions, he actually refused to even go for an MRI, despite the importance being explained by his clinical team. Now, we know that best practice for a patient with a Category 4 pressure ulcer with underlying osteomyelitis includes a multidisciplinary team approach, as well as antibiotic therapy and strict attention to all elements of skin bundle care. We know that there is a high risk of sepsis, and that can lead to multi-organ failure and death. And whilst the paper on screen relates to pressure ulcer pelvic osteomyelitis, it is of interest because it shows that treatment failures are associated with a lack of formal care support, post-traumatic neurological deficits, and a high CRP. Our patient had declined a care package, he was insensate, and he had a bony infection. The scary part of this study is that if treatment fails, it is associated with a 1-year mortality rate of around 23%. Whilst preparing for discharge home to await potential plastic surgery, one of my community district nursing sisters, who was very proactive, had a read at my case notes. And I was obviously suggesting that this gentleman was to go home on a therapy mattress, a powered mattress, and hopefully to stay on this side. So the district sister contacted me and she said, listen, in community, our patient is only on a level 3 static mattress. In our language, that relates to a hybrid mattress due to the risk of smoking. And he also has a blanket most times over the mattress. She advised he would be sitting up in bed every time they were visiting and would say his back was too sore to lie on his side. So now we have our Kobayashi Maru. In my opinion, the patient required a powered mattress. Without this mattress, I was concerned that the mattress or the pressure ulcer would deteriorate further and the patient would actually die from infection. But I was also conscious of the fact that if the mattress became punctured, the pump would work harder to keep that mattress inflated. And when the puncture is caused by a cigarette or an ignition source, the escaping air acts as bellows and can cause the fire to increase intensity and to spread quickly. A colleague, Samantha Haig, did some work with the North Yorkshire Fire and Rescue Service, and they actually set a powered mattress on fire and found that it took over 10 minutes for the pump to stop working. Meanwhile, the air pump from the mattress caused the fire to burn intensely and to spread quickly. So given the fire risk, we actively retreated. The safest course of action appeared to be to continue with the hybrid system, the non-powered system. However, in October, I became really concerned about this gentleman. He was very thin and gaunt. He was still declining a care package. The coccyx bone was exposed. Behaviour remained erratic. He was smoking in bed. There was clear evidence of alcohol excess. And he, as I said, he was declining his care package and was very dependent on his community nurses who attended 3 times a week. Now, given that plastic's opinion would take around 39 weeks, believe it or not, in Northern Ireland, and surgery, if appropriate, could be 3 to 4 years away, I decided to double check the rules about the powered mattress. And I began to wonder and question, was this patient at a greater risk of death by fire on an electric mattress or death from infection? And I wondered if the risk of death on a hybrid was less than that of an electric mattress, and if the risks in relation to both could be mitigated. I noted that all therapy mattress covers and cables have to meet strict fire regulations, and I wondered if a fire mat could be placed on top of the blanket when he was smoking. So lots of ideas going around in my head. So I sought help and advice from a number of experts, including our community nurse team, risk and governance, the Senior Estates Office for Fire, who put me in contact with Peter Cassidy, who will speak to us shortly, from the Northern Ireland Fire and Rescue Service. So that was really helpful. So we carried out a risk assessment. So in relation to smoking, we carried out a Safer Together fire risk assessment, which Peter will talk to. We noted our patient declined to get out of bed to smoke. He was given advice regarding the safe disposal of cigarettes and provided with a metal-lidded ashtray. That's probably something that I wouldn't have naturally thought about. It sounds so basic, so simple now, but at the time that was like, yeah, of course that makes sense. We gave him support and offered support re-smoking cessation, but that was declined. And we made sure that, the patient knew how to seek help should a fire occur. We provided the patient with fire-resistant sheets, pillowcases, and a duvet cover. We considered putting a double mattress cover over the hybrid, but then I learned that the hybrid we were using had an inner fire sock as well as an outer fire retardant cover. We knew that there were emollients in use and had to be conscious of the fact that they act as an accelerant. We did provide him with a fire blanket, and we asked him to cover himself with that when he was going to smoke in bed. And our estates office actually provided him with a fire extinguisher. The fire extinguisher was kept beside the bed, and believe you me, this gentleman knew how to work a fire extinguisher. He was able to tell me about letting them off in school in his younger days. In relation to alarms and others, we made sure he had a working heat detector in the kitchen, a working smoke detector in the hall, and the fire service put an extra smoke detector above his bed. And also, again, simple things that I wouldn't thought of, the gas boiler had its annual safety check, and we made sure that that was going to be assessed on an annual basis. In relation to physical impairment, another thing that I wouldn't have thought of was that Peter and the Northern Ireland Fire Rescue Service contacted the Patients Housing Association's fire safety officer to ensure that there was a personal evacuation escape plan in place. They also requested that his front door was numbered. It didn't have a number on the outside for ease of identification. You can imagine if there was a fire and, you know, people were trying to work out which door they needed to go to. It's important to have that simple, you know, number in place. We made sure that his wheelchair was kept beside the bed for ease of access. This gentleman could get in and out of bed himself. There were no obstructions between the bed and the wheelchair, no obstructions between the wheelchair and the front door. But one thing we did note was that his wheelchair was in very poor order, and that was reassessed by OT, and he was provided with a different wheelchair. Another important thing was that the fire and rescue service made sure that they had kind of an alert on this gentleman, his address, and that they would always respond for any requests for help. Back to the powered mattress, we kind of thought, should we now put the powered mattress in? But there were lots of further issues, and there was a failure to engage with the protective measures that we had put in place. So we decided for the time being to continue with our hybrid mattress. We did try to deal with mental health issues, but there was just a failure to engage. This gentleman was very astute. He had capacity. He was very educated to the risks of, you know, the smoking in bed, the fire. And we did continue to escalate issues in relation to per mood to, for example, his GP. So I think it's really important to remember that pressure ulcer treatment cannot always be optimized due to the potential risk of a catastrophic fire, and that those risks need to be thought about and mitigated. And we need to balance the risk of fire against the risk or treatment of pressure ulcers. There are a lot of ethical issues. Is it right to deny a therapy mattress to someone who smokes if they have capacity? There is a real risk of serious illness and potential death due to infection. But what if capacity fluctuates due to alcohol or drug abuse? And what about others who live in the vicinity who could be harmed with a catastrophic fire? Would you retreat, wait, or try to change that scenario? Samantha Haig, who I mentioned earlier, actually took this issue to their ethics committee, which blew my mind. And initially, as far as I understand, that committee felt the answer was not to provide the powered mattress. But when Sam discussed the consequences of a Category 4 pressure ulcer, they felt the situation had to be reviewed on an individual basis. Sam advised that their trust now requires a fire risk assessment to be done as part of their community mattress ordering protocol. And that assessment helps practitioners to decide if they should or should not give a powered mattress. And another thing they did was add a QR code with fire safety info directly onto the pump of the mattress. So folks, I'm going to stop now and hand over to Peter, but I'm really, really keen to hear what you're doing in your locality. So please do share your work in the chat box.
Thanks, Jeannie. That's great. Lots to think about there. So we'll take questions at the end, and moving swiftly on now to Peter Cassidy, Station Commander, Northern Ireland Fire and Rescue Service. Over to you, Peter. Thank you.
Good evening, everyone. Thanks for your time this evening. My name is Peter Cassidy. I'm from Northern Ireland Fire and Rescue Service, and I'm a Station Commander in the Protection Department, and I'm based in headquarters, which is in Lisburn in Northern Ireland. I've also been doing a PhD in human behaviour and fire for the last 8 years, and I'll be graduating in July this year. So today what I want to do is just give you a bit of an overview, a bit of an introduction, and then tell you the outcome of my PhD, which was the Safer Together project that we did in conjunction with the Belfast Health and Social Care Trust. And that is ultimately how Jeannie found out about the fire risk associated with our powered mattresses. And then I'll finish off by giving you a case study of how the project has worked in practice. So just before I begin, I just want to give you a warning. This presentation will include discussion of fire fatalities. It's important to let you understand why people are dying in fires and help you prevent them in the future. So Imagine, and I saw from the poll that a lot of you are giving care in the community. Imagine you are giving your care in the community and you're going around from home to home, providing the care for your patients and service users. Imagine you got to a property and you saw there were blackened windows on the outside, or like we had recently, a smoke alarm sounding from inside the property. You may even see smoke issuing from the property, and you're then faced, do I go into the property and help the person that I'm here to care for, or do I call the fire and rescue service? Unfortunately, if we look at the fire fatalities, and as part of my analysis of fire fatalities as part of my PhD, we looked at all the fire fatalities between 2009 and 2019. And what is significant for all of you on the call today is that 29.8% were found by a carer in the community. So someone who was providing care for the individual was going to their property to provide the care that they normally did on a daily or weekly basis, found that the person that they were going to care for was unfortunately the victim of a fire. And in 9 of those cases, the person actually went into the property, could maybe see some sort of fire, so you could see some symptom, whether it be a smell of fire or a smoke alarm sounding. But they went into the property and they saw that the person that they were there to care for, it was unfortunately a fire fatality, and the fire had been extinguished in all 9 of those cases. So you can imagine it was quite traumatic for those people that were providing care in the community. In 2 cases, they heard a smoke alarm from the outside and didn't go into the property, called the fire and rescue service instead. And in 3 cases, they noticed the signs and symptoms of fire and didn't enter the property either, but called the 999 and the fire service went out as a result. The other fires were identified by neighbours, passers-by, residents, and automatic fire alarms in the community. But I think it's significant for you lot that the carers in the community found the victims in 29.8% of incidents. If we also look closer to now, we have the fire fatalities between 2020 and 2022. Whenever we look at them, the older people are dying in fires. It's 93.8% of our fire fatalities in Northern Ireland were over 50 years old, and they were caused by, the majority were smoking, then open fires in the community, and electrical devices in the property. But significantly, we had 53% of the fire fatalities were already known to our partner agencies and our care services in the community. So that's why we have been working closely with our partners in the community, trying to identify fire risks and deal with them before they cause serious harm. So, and that's what my research is all about, and my PhD is all about. I did a field fire analysis, which looked at all the fire fatalities between 2009 and 2019 to see who are dying in fires, why are they dying in fires, and what can we do to prevent that in the future. I carried out interviews with carers in the community, and I carried out focus groups with people that are in contact with older people in the community. And then lastly, I carried out a co-production project with the Belfast Trust, and I'll tell you a little bit about that now. The Safer Together project was funded by the Social Work Strategy in Northern Ireland, and we used co-production to create resources which were guided by the previous phases of the research. And we did a pilot study in Belfast where we worked with social workers to provide resources to help them reduce risk in the community. The Safer Together project team was made up of a social worker from the Belfast Trust, a fire officer from Northern Ireland Fire and Rescue Service, and then myself, who was obviously had a foot in each camp between the Fire and Rescue Service and also the Ulster University doing research. So what we did was we talked to social workers in the community. We talked with family, friends and neighbours of older people in the community, and we talked to older people themselves to say, what do you need to reduce risk in the community? And what can we give you to help you reduce that risk in the community? And the outcome of the co-production were a number of things. So the first thing is we created a fire risk awareness form to be used by health and social care workers. And although it was done with social workers, we framed it so that it could be used by anyone in health and social care. And it is a more detailed, person-centered risk assessment of uh, fire risk in the community. And I'll tell you a little bit about it more in more detail later on. We also developed a training package that we could use with social workers and other health and social care workers in the community. We created a poster because the feedback was, well, fire safety is important to me, and it's important that I safeguard my patient, my service user, but often I forget about it, and if it's not put in front of me, it goes to the back of my mind. So that's why we created a poster to put in the offices of Belfast Trust, so that they had that in their mind whenever they were out with their service users. We also created a number of leaflets. You'll see the top one there is a door hanger that was created for older people, because the older people themselves said, well, the advice that the fire service gave me if there's a fire in my property is crawl out of my house. The older people were telling me they can't crawl out of the property, they can't even walk. So the door hanger was to create a bespoke fire escape plan for the older people, which they could then hang on their door for a period of time just to remind them of it in case they needed it. Then we provided a number of smoking aprons. The fire fatality analysis showed that smoking was the biggest cause of fatal fires in Northern Ireland. Social workers were telling us they're constantly being having to deal with smoking as a risk in the community. So we provided smoking aprons for use whenever people were smoking, whether they were wheelchair bound or they were in their chair during the day, so that their clothing didn't go on fire. We also provided some alarms and torches. The fire fatality analysis identified that there were a lot of older people that were dying in fires that had smoke alarms sounding in their property, but in a third of cases, they didn't respond. Nobody responded to the smoke alarm. So we provided an alarm for older people, and that was the idea of older people themselves, that if their smoke alarm went off and another alarm went off, it might alert more people. And we provided torches just for an emergency if they needed it. We also provided some fire-resistant bedding that can be used in the community, because social workers were challenged, just like Jeannie was telling you about an incident that they've had. Fire-resistant bedding helps mitigate that risk in the community, and Jeannie's patient that she discussed earlier benefited from having the bedding from the Safer Together project. Lastly, we created some training videos that could be used by social workers and other health and social care workers in the community to help them be able to identify and mitigate fire risk in the community. So just to give you a bit more detail on the fire risk awareness form, I'm sure some of you already have something similar, but our fire risk awareness form is very bespoke to social workers and health and social care workers. It was created with the social workers. So we went through the risks that they often see in people's homes. We went through the risks from the fatal fire analysis. And basically, if you identify a risk in the community and want to answer any of the questions with a yes, then there's an action associated with that that helps mitigate that risk in the community. So you see here, if there are emollient creams used, if the answer is yes, then there will be an action associated with that. Same for the airflow mattresses. If they identify that there's an airflow mattress in use, then they will obviously have actions to help reduce that risk in the community. We have a number of training videos. We have the video for social workers and health and social care workers. We have a video for older people themselves, and we have a video for family, friends, and neighbours of older people. We also have some case studies of videos that are good news stories that of how intervention in terms of fire safety has helped prevent fire starting in the first instance. We put all this together as part of e-learning, and it's available on the portal of the Belfast Health and Social Care Trust. I also have links now. We were discussing at the start. Sarah was talking about any links that you may require. I have links to several things that I would like you to have. You can get it off these QR codes, or you can get it sent to you from the Society after this webinar. The first one's a research paper that I had published, which was the initial stages of the research in terms of the fatal fire analysis and the interviews and focus groups. Then the videos that we created as part of the project are available on the QR code, and the e-learning. It's a link that is available for a review, but it's not to the portal in the Belfast Trust, but it will allow you to see the e-learning. The other resources are available on the Northern Ireland Fire and Rescue Service website, and I'll tell you a little bit about that in the conclusion. So I just want to finish off by giving you a case study of how this has worked in practice, as well as the case that we had with Jeannie. We have loads of case studies where the close working between the Health and Social Care Trust and the Fire and Rescue Service has prevented serious injury and fire in the community. And one was a case that we had where there was a residential fold that the fire service were attending, and it works both ways. So it's the referral pathway can go from the fire service to the trust and from the trust to the fire service. It was a residential fold. We had 16 calls to a lady who was smoking in bed. One of the calls was the lady was extinguishing cigarettes using tissues, and unfortunately the tissues went in fire, and the fire service were called as a result. One of the crews identified it to me, and then I was able to link in with the social worker for the lady, and we were able to put several things in place to help reduce that risk in the community. First thing was we carried out a fire risk awareness form. We completed a risk assessment, and we identified some issues. First one was obviously the smoking in bed. For that, we installed another smoke alarm in the bedroom, in the lady's bedroom. We installed fire-resistant bedding in the lady's bedroom, and unfortunately, as you can see from the fire, she had a fire in her property. Luckily, we were able to give her some survival advice, and she was able to get down on the ground, and she was rescued by fire crews. Okay. But the early warning given by the smoke alarms and the work that we did to reduce the risk of the fire and the severity of the fire helped prevent serious injury in that case. So lastly, the project was about working with the Belfast Trust and the Northern Ireland Fire and Rescue Service. We recently evaluated the project, and we identified what went well, what didn't go well, and what could be improved. And that will be taken forward, and we will work together with the Belfast Trust in order to make the project better. Working in partnership definitely works. It protects the community. It protects the people working in health and social care, and it also prevents us from having to go out and deal with the fire in the long run. The e-learning was made available on the Belfast Health and Social Care Trust Learning Portal, and it's now being sent out in line with their mandatory training that they do every year. The resources, one of the questions on the chat was, is the fire risk awareness form available? There is a copy available on the Northern Ireland Fire and Rescue website in community safety section, and the Safer Together project has a page within that community safety section that you can access. So I'll be happy to take any questions that you have in the panel chat.
Okay, thanks, Peter. That's great. Again, there's quite a bit of discussion going on in the chat, so you might want to have a look at that as well. But hopefully we've got some time just to sort of raise some of those questions or issues. And final presentation, I'm delighted to invite Dr. Baron de Haar, who's Director of BSS Healthcare Limited, who's going to give the final presentation. Thanks. Over to you.
Good evening. Baron de Haar. Have an interest in what is carrying on the fire prevention side of things, in that I've been involved with the development of the current standards for flammability testing for cushions, and I'm involved with the extension of that work into flammability standards for mattresses, just as a starting point.
You want to put your presentation on to full screen there? That's lovely. Well, that's brilliant. Thank you.
It's very difficult to follow the likes of Jeannie and Peter because
No, you're doing well. Fantastic.
They are fantastic presenters and fantastic material. So we have the expression after the Lord Mayor's show, we know who clears up behind all the horses. So this is my role this evening. So the big question for me, and I think this has been touched on heavily by Jeannie, is from what are we protecting the patient? Is it from fire or is it from tissue injury? So in what way does the patient come first? So where and what are the risks? I'm going to touch on the balance of the environmental risks versus the support surface risks. But an interesting way of approaching risks is if we look at all the different sources of risk, if we score them from 1 to 5, if anything has a score, then the usual approach in the risk world is that you multiply those together to give a score. And if it comes to very high, then you do something about it. If you've got lots of ones multiplied together, they come to 1, so it's not particularly important. We keep the zeros out because anything multiplied by 0 comes to 0. So as we go through this presentation, we look at various things that we may need to bring into consideration. So looking at what I call the environmental risks, those are outside the patient. A top-down view could be, where is the person in the first place? I see from the survey we did at the start this evening was that most of the attendants on this webinar this evening are working in the community in the domestic situation. But the risks probably these days are lowest in the hospital because people don't smoke in there and there's lots of people around keeping an eye on what's going on. So if a fire does appear, there are good ways of putting that out. Then we come to residential homes. Residential homes are somewhat regulated. People aren't supposed to smoke in them. And quite recently, the legislation in the UK or at least in England has changed and saying that new build residential homes have to have sprinklers installed in them. Then we come into the domestic side where we can't control very much, as Jean has pointed out, what people are doing in their own homes. And what's considered the biggest risk environment is probably in prisons, where people every now and again decide to set light to everything around the place to make life a bit more interesting than it was otherwise. So within that, what is inside the person's environment? The risks can come from furnishings, come from fires, are there open fires? And as Jeannie pointed out, I think, and Peter, how far are people from the exit? If you need to get away, is there a long distance? Can you get away easily? And are there obstacles in the way? And what controls are in place around the place? So Peter again has just touched on, and Jeannie, are the fire extinguishers available? People can use them. Fire blankets, are sprinklers around the place? The discussions I've been having with the international community about to what extent the fire resistance should be in the mattresses that people are lying on versus the environment. And in North America, the approach is very much that any place, anybody's on a medical device, there should be sprinklers around a place. And so if a fire appears, the sprinklers will put the fire out, and therefore it's not so much a worry about getting the person away from it. So there are different approaches in different parts of the world. So getting close to the person, there are little things that can add to the risk. Is the person oxygen? If there's oxygen flying around the place, as we know, a fire burns much better than if there isn't. We've had the subject of emollients mentioned, and most of those are based on flammable solutions to make them work as carriers. And the emollients not only on the person, but also they get into the bedding and into the clothing, and those add to the fire risk around the place. And then we have alcohol wipes. I have, in part of my life, had quite a lot of information from people working in operating theatres, where the cauterizing devices have got too close to the drapes that have had alcohol on them for whatever, and flaming drapes have been thrown into the corner, stamped on while people get on with the surgery. So there are agents around the place that we have to take an account of that can exacerbate any risk of fire. So dealing on with the person, we've got quite a few of these elements covered by Jeannie in particular. Is the person a smoker? Are they on drugs? Sometimes they're prescribed drugs, and those drugs can impair the person's mental and physical abilities. Some people on recreational drugs, those drugs can also impair their abilities to handle the situation. The mental state is quite important. If you've got a suicidal view of life, then you're not going to be as careful as somebody who really wants to carry on living. But people who've got dementia, various other elements need to be brought into the risk equation. As mentioned earlier this evening, mobility status is quite important. Does the person, to get out of bed, to get out of the building, have to get into a wheelchair? Are they able to crawl to a door? Are they aware of where the door is? Going on down through this, there's clothing materials. I've known a number of cases reported in the domains that I've been in of people being in a perfectly safe environment, but children particularly wearing inexpensive clothing, some of it getting too close to fires and the clothing catching light. So we look at the clothing materials. We also look at the materials on the beds. We talk about having interfaces that might be fire resistant. But if we're looking at putting somebody on a pressure care device, are we finding that all the different layers of the person's clothing, their bedding actually stops the device from working well? After all, we know that the highest majority of pressure injuries are stage 1 and stage 2, and most of those are skin-related damage rather than deeper tissue damage. And all the things that we put people on, we put a lot of interfaces that may or may not aid the work of that device we're putting people on. So those need to be brought into consideration. And a lot of times we don't have any control of what people wear as pajamas and what they put on the beds. Does the person have anybody at hand who can help them in an emergency? So if the answer is yes, they might be a lower risk than somebody like Gina's case study who is looking after themselves allegedly at home. And let's come from the other direction. We've been so far talking about all the things that are around the place that we might or might not be able to control. But ultimately, we have the patient. And what is that patient's risk of tissue injury? So coming from the clinical end of things, where is person on the scale? We know that we have intrinsic factors, and we discussed some of those as to the person's risk of what they're being given as their pressure care device. And we've also got the extrinsic factors, pressure, share, microclimate, and those do influence our decision in everything else being equal world of what would be the best product for that patient. And we end up with a preferred management device that could be foam, it could be modern materials like spun or 3D plastics like the picture on the top right. We have alternating pressure. Now, interestingly, this country, UK, has been heavily oriented towards alternating pressure. You go to other parts of the world and they're much lower incidence of use of alternating pressure. I think the marketing departments, originally of Huntley and others, have done a very good job of making that a first choice. And I know this evening's discussion is about air devices. And the other area there is what is these days, I was told at the conference last week, is called moisture management with airflow. We used to call that a low air loss, but that's another source of air that's being perhaps added to what is the person is lying on. So where I sit, and I have no qualifications in tissue viability or tissue integrity, I would say if the risk of fire is high, I would not go to prescribing an airflow device, and I'd go for other alternatives. There are air-filled devices which are not being pumped, which give you good immersion and good pressure redistribution, and also ones that give you good microclimate management without having to use air. So maybe for me, that would be the first choice, but I'm not the professional, so you shut me down in the moment if you wish. But Jeannie asked me to talk about this because I have been involved in flammability testing. And on that front, what do we need to take into account? Possibly we need different flammability tests for different environments. If we're going to put a mattress into the prison environment, then people say there's greater risk of somebody trying to set light to it, and therefore it has to have greater fire resistance. But we also have to look at where, from the mattress point of view, where the sources of fire might be. How external are they going to be, or could they come from maybe electrical fault within the device itself? We like to look at the materials of construction because we're trying to balance between what will give you the best tissue care and what has to be added to the product to make it fireproof. And actually, do you test for the composite, which is the cover on the core material, or do you just test for the covers and hope that that will be your protection and therefore can have good deep tissue care by what's inside the mattress? When it comes to fire testing, there are two areas that people look at. One is how readily does a thing catch light? So if something hot gets next to it, is it suddenly going to burst into flames? And the comparison of that, does it self-extinguish once it has come alight? So if there's a fire nearby, will it put itself out reasonably quickly, or will it get worse and worse with time? Another consideration, if something is burning, does it start dripping, say, burning materials elsewhere, and it spreads the fire? So these all come into consideration when choosing materials. Another important area is actually poisonous gases from the item that's burning. A lot of foam, when you set light to it, will actually start producing cyanide-related gases. So you may not die from the burns themselves, you'll die from the gases that are being produced. And that is a major consideration, I think, when considering the materials that you're putting your patient on. To meet the fire regulations, people add fire retardants. And those fire retardants, for example, in this country, we put a lot of melamine into the foam to stop it from burning. But that is a very abrasive material, and the foam doesn't last very long. So again, it's not the best of materials. But we also have to look at the biocompatibility of the fire retardants. And in the States, in California in particular, they've now banned a lot of the fire retardants because they're considered to be probably more harmful for the person against the risk of the product catching fire. The other thing, of course, is that a number of fire retardants can be sprayed onto a cover or a cushion, but with time, do they get washed off and they're no longer there? Or are they covalently bound to materials, so they're for the life of the product? So if you're a manufacturer, you're trying to make products that meet the clinical requirements, also meet the test requirements, and all this list here comes into consideration. So very quickly, what are the flammability tests? Nearly all the flammability tests around the place for mattresses are really have their DNA from furnishing standards. And the furnishing standard, a typical test is to put a heat source between a back of a sofa and the seating part of the sofa to see what happens when that joined together. Well, mattresses don't have joining points like that. In the UK, the regulations say that cover domestic furnishings, and they say what should be done and what they should be tested to. But they specifically say that medical devices are excluded, maybe not exempt is a good word, but maybe excluded from these requirements. However, medical device manufacturers are still looking to do what they call a cigarette test. which is the least aggressive test. Now, cigarettes are not a good standard because this test that I've seen being done indicate that there's no such thing as a standard cigarette. There can be 300% variation in heat output from one cigarette, one end of the packet, to what at the other end of the packet. Also, people don't like using cigarettes because they're putting nasty things in the environment of the test area. The National Institute for Safety Testing Standardization and Technology, beg your pardon, in the States, did actually produce a standardized cigarette, but they didn't make it available for anybody except their own labs to use. So in a moment, I'll talk about what is there to take its place. But at the next level, the level 1 is a flame test, which is a butane flame. Again, people find that very difficult to make that reproducible. In more aggressive areas, you've probably heard of crib 5 test. This is a little pile of balsa wood that's put together, and it's designed to burn for 5 minutes. And for more aggressive situations, they've got a crib 7, which is a slightly bigger pile of wood that's designed to burn for 7 minutes, and then you see what's happened to the thing you're testing, whether the flame goes out or whether it's been destroyed. So that's what we have in the furnishing world. In the cushion world, we have gone away from the furnishing standards, and there's a standard ISO 16844 Part 15. This had a small amendment came through last year, and that has created what they call a surrogate cigarette, and that is a very easy to produce nickel chromium coil, and you adjust the amount of voltage to get the temperature that would be the equivalent of the burning part of a cigarette. And incidentally, since cigarette tests were first introduced in furnishing, cigarettes have moved on. They are obliged to be self-extinguishing if people aren't putting air and oxygen for them. So the original cigarette tests are not the same ones they're using for testing today, so not a very good source of a standard. The requirement on this ISO standard is you test a complete product, so it's the cover with a substrate in place underneath it. The FDA has accepted this as being a replacement for the old flame and cigarette tests, and it's also cited in the European wheelchair standards for the cushions that go onto wheelchairs. So where are we with mattress flammability standards? The cushion test method I've just described has been considered for mattresses by the US Consumer Product Safety Commission. Otherwise, people are using furnishing standards for now, but these concentrate on foam support surfaces. They're not really designed to go on air pump products. But I'm leading a group now starting work on a flammability standard for mattresses. So hopefully at the end of it all, we'll end up with something that can be applied to all kinds of mattresses, not just foam ones. So in the end, we have a compromise. And the balance that we saw earlier in Jeannie's slides is, when do the risk scales tip between protecting the person's skin and protecting the person against possible death from sepsis or infection versus asphyxiation while burning to death? There's no right answer, and each person in each situation needs its own risk assessment. Thank you.
Thanks ever so much. That was really interesting, and there's lots going on in the chat. I'm aware, folks, that we're at time, but if it's okay with you, I think we just, would be good to put a couple of questions to our panel. There's been a lot, folks, of discussion around actually what is a hybrid mattress, because we know that some hybrid mattresses are a combination of foam and pumped air. I think someone did mention that they have a static air and foam hybrid. Could you just confirm, Jeannie, because there's some confusion, because some are air pumped as well?
Yeah, absolutely. Now, in our situation, we were using a hybrid, which was air and foam, but it wasn't pumped. It's the air cells that move with the patient as they move. So it's not actually powered, okay? But yes, you absolutely can have powered hybrids. You can have hybrids made. I'm sure Baron would be fit to say, of many different materials that are pulled together. So even the definition of a hybrid can be quite difficult to nail down.
Absolutely, thank you. There's a lot around this, maybe the culture of not really engaging and taking this seriously. There was a comment about sort of just doing quite a casual risk assessment, but they don't actually explain the consequences of risk to patients. It's really a bit like a tick box exercise. We need to do better than that, don't we, Peter?
Yes, well, the National Fire Chiefs Council are moving towards a person-centered risk-based approach. So rather than just going in and being a tick box exercise, that they're actually looking at the person, which is what I'm glad to see, because from the fatal fire analysis, we can see that a lot of the fatal fires could have been prevented had we had taken a person-centered approach. So rather than just saying don't smoke in bed, we try and make that environment as safe as we can for that person, because their behavior is not going to change. So yes, the culture does need to change, and the National Fire Chiefs Council are trying to do that.
And is that going to be sort of trying to standardise? Because it doesn't sound like there's this sort of collaboration across the whole of the UK. So what work is being done to try and improve that?
Yes, so the National Fire Chiefs Council are really behind fire services, linking in with partners and trying to promote fire safety with their various partners. They have done work in the past with various services throughout the UK to try and improve that relationship, and they do support us. I think it was in 2014, when they realised that older people are dying in fires, they encouraged fire services to reach out to their partners and try and reduce fire risk among older people. And that's ultimately where my project came from.
Okay, thank you. Baron, there's a couple of comments there around vaping and the risks associated with that. Have you got any comment on that? And is that a risk in terms of the materials that are used for these mattresses?
The risks really of any heat source are going to be the same. So vapes do produce quite a lot of heat. They, unlike a cigarette, they're less likely to fall from the hand of, or bits fall from the hands of the individual. So they are a more integrated structure. But I think any source of fire needs to be considered in the context of that individual. And if you can't control that risk, then you have to look at what's underneath the person and decide whether the support surface is going to be the fire barrier and reduce the impact on being able to manage the person's tissue integrity.
It's a huge ethical dilemma. You know, you've all sort of mentioned that. You know, there's I think from a clinical point of view, there's this need to do all we can, and it's, you know, we've gone through that whole blame culture, haven't we, Jeannie, in clinical care? You know, if people get pressure damage, it's because we've been, you know, we haven't done all that we can. So I think, you know, powered air mattresses are often put under people that possibly don't always need them. But when you're faced with someone who does need that, but the scenario that you gave us, it's a tricky balance, isn't it? And people must really struggle with that.
They do, Sarah. And I think we need to learn more about what the other materials are that we could be using in those situations. I mean, I certainly don't feel I know enough about what else is out there and what other materials. I mean, I don't consider myself to be stupid. I think, you know, I'm long enough in the tooth to have seen, you know, a good many different systems, but I know that there's a lot more we can learn, perhaps, as Baron said, from other countries, other health services. There's a lot to learn.
Yeah, and I think sometimes, you know, people feel they're restricted by maybe equipment formularies, but, you know, there's always individual decisions, isn't there, on a case-by-case basis? But I suppose unless clinicians have that knowledge, they wouldn't know who to approach about that. So it goes back to the procurement, isn't it, of this equipment, and the people doing that having the knowledge to make sure that they've got equipment that's going to meet the needs of everybody, really.
Absolutely. It would be so useful, Sarah. Maybe it does exist and I just don't know what it is. But if there was a catalogue of all the different types of systems that you could potentially purchase for that individual, if it wasn't on your normal list of products that you use within your trust.
One of the challenges that somebody in procurement doesn't know one mattress from another. So they really rely, I think one of the blogs, the first blog is talking about this, that we've got coming up available shortly, is who is advising whom. The tissue viability advisor may be expecting procurement to be able to tell them what to do. The procurement may be doing the vice versa. So whose responsibility is it to know what's all available and to describe in a procurement tender what the requirements are for the products being tendered. And my experience of people, they are procuring so many different things, they haven't got the knowledge, so they do rely on their clinical advisors as to what should be on the tender. And as Jeannie says, even an experienced person like herself doesn't really know necessarily everything that's available. So it is a big challenge.
It is a big challenge and a big shift, I think, for everyone's knowledge, isn't it? And I thank you all for your time this evening. We hope to see you again at some point. Thanks again. Bye-bye.